Sorry, I realized I was muted. Good morning. This is Dr. Chad Versio. I'm the chair of pediatrics here at RUHS. Very happy that you've joined us this morning, and we're lucky to have with us Dr. Bruce Wang, one of our infectious disease doctors here at RUHS, who's going to speak to us on the topic of testing and coronavirus, and talk to us about the different testing modalities. Before we get into that, we are going to review some of the local statistics. So Riverside County has tested about 45,000 patients. As you're probably aware, we're starting to test a lot more asymptomatic individuals. We have about 3,700 confirmed cases. There are about 220 hospitalized patients, about 73 in the ICU. Both of those have been fairly stable and maybe slightly declined in the number of hospitalized patients over the last week or so. And then we have 141 deaths so far. That has kind of gradually increased. If you look at the curves on the county website, you can clearly see that we are in a plateau phase currently, and which is good news. Hopefully we'll start to see a downtrend on that fairly soon. If you look at San Bernardino County, they have about 1,800 confirmed cases. Their doubling time is currently estimated to be about 9.8 days. And they have 85 deaths so far. Their hospital census, they have 152 positive patients with 101 suspect across the county. This is not just at Arrowhead. And then they have 54 ICU patients with positive ICU patients with 19 PUIs. So good thing is that this isn't overwhelming for our hospital capacity in either county for sure. So I'm going to go ahead and turn it over to our team. At this point, I believe we're going to have the video first, and then we're going to have Dr. Wang go through the modalities of testing for COVID-19.
Hello, my name is Bruce Wang. I'm one of the infectious disease doctors here at RUHS. So I was asked today to talk a bit about our diagnostic capabilities in the COVID pandemic at this point. Currently, we have 3 machines in-house that can perform COVID testing, and they're being validated: the BioFire, the Abbott, and the Cepheid at this point. They're all PCR-based machines, and they all have pretty rapid turnarounds. The differentiation between these tests are how sensitive the tests are, and along with the other capabilities of these tests. I think a lot of people have heard about the Abbott Real ID test out in the community at this point. It's a very rapid turnaround test. Positive results can come back in as quick as 5 minutes, whereas negative results can come back in about 15 minutes. It's a very nice quick screening test. The caveat with this particular test, of course, is that it's not the most sensitive test. So there's a chance that it can also miss positives, and it has what we call a very high limit of detection, meaning you have to actually have a significant amount of viral load. Otherwise, it does have a lot of what we call false negative testing. So for a very quick test that you may want to do a quick screen for, it's a pretty decent test, but it probably isn't the first test you would want to reach for if you have other options. The other 2 tests that we currently have in-house and being validated is the BioFire and the Cepheid. Both of these are PCR machines. The actual runtime on each of these is about 45 minutes once you load the cartridge in the machines. The nice thing about these is there are multiple modules, so you can run multiple tests at a time. They're very quick and efficient, and they're very sensitive and specific. So if the sampling is done appropriately, you often can get pretty good, reliable tests. And again, you don't have to send these out to an external lab, so that's very nice too. The nice thing too about these 2 machines is they actually have a lot of other capabilities. Here at RUHS, we're not just focusing on just COVID. We have to really look at the long-term care of our patients. What's going to be happening next season? What's happening in the community? The Cepheid was originally brought in to help with our OB population because it can do what we call rapid group B testing to help minimize pregnancy complications, and that can be done in-house. As we know from public health before all of the COVID pandemic, there's a significant outbreak and essentially could even call it a pandemic of sexually transmitted diseases. And the Cepheid actually can run gonorrhea and chlamydia testing in-house very rapidly. So if you're coming into the clinics, into the emergency departments, this can be run pretty quickly, and the doctors can and nurses can try to get an answer quickly to treat patients coming in for this. So this would help both on the inpatient ED clinics and in the community overall. The BioFire is actually a very interesting machine. On top of potentially being able to test for COVID, it's going to run on panels. So, for example, especially during the winter time, when you think about flu or other viral infections, the panel can also test for other viral infections. So let's say you come in and you don't have COVID infection or flu, it may find another viral infection to help detect and explain to you why you have those symptoms. In addition to that, it can test for stool infections, blood infections, and then also what we call CSF or spinal infections, which are notoriously difficult to diagnose because a lot of these tests are sent out. So those are really great capabilities, not just for currently now with COVID, but looking long term for RUHS. In the process of this, RUHS has also expanded mass testing for COVID as well. And what we're trying to do is create a real-time PCR system in our facility so we can run massive amounts of tests at once. What this would likely provide is being able to help potentially open up more time-sensitive procedures such as surgeries and other surgical-based procedures so that more patients can be tested. And this will hopefully allow and reaffirm the community that we're doing everything we can to try to ensure the safety and health, not only of our patients coming in here, but the physicians and employees as well. There's a lot of different uses for all these tests. The workhorse test, again, is these PCR-based testing. And what we're going to be utilizing those for is to provide quicker turnaround times and answers for patients, physicians, nurses, all our healthcare providers coming in so that we can provide the safest and most comprehensive hospital-based environment here for everybody coming in here.
Thank you, Dr. Wang, for providing that video. I'm excited about quite a bit of this testing capacity or these different modalities. So why don't we transition into your slideshow? So if you can go ahead and share the screen so we can see the slides.
Is everybody able to hear me at this time?
Yes.
Okay, let me get the slides set up. As I'm setting that up, again, thank you for everybody joining the webinar this morning. I really appreciate being here, being able to just give some more information on testing modalities, give you another maybe more detailed view on some of these testing modalities, and then hopefully leave it open to discussion and any questions from other healthcare providers or facilities on just really anything coming off the top of your head here. I just realized I don't know how to advance. Oh, here we go. Okay. First time I'm using Microsoft Teams. So these are what we're planning at RUHS or have on site, and they're pending validations. I'm going to go through these really quickly, just to touch about the pluses and the minuses and kind of give you some time frame. So as you saw in the video, there's the BioFire, the Cepheid, the Abbott ID Now. The real-time PCR uses reverse transcription methods. And then not in the video, but something that I'm sure everybody's thinking about just because it's all in the news is serology at this point. So we can briefly touch base on that. Right now at RUHS, what we're doing, because none of these are up and running, is we're doing send-outs. So these PCR tests either go to public health or secondary labs like Quest and LabCorp at this time. The turnaround with public health has actually been pretty good. If we look at it from the beginning to now, that usually can come back within a 24-hour period to up to 48 hours. LabCorp and Quest do take a few days, and these are usually more the methods we use in the clinics and the emergency room if patients are just coming in for illnesses but not being admitted. But it'd be very nice, I'm sure, to have these in-house so we don't have to send them out and get a more rapid answer for everybody involved. To briefly touch on the BioFire, that's again the machine that kind of had the red outline. It had 4 little modules on there. This uses a nasal pharyngeal swab. You can stack and create up to 12 modules, so you could run technically 12 tests at a time. And once the lab person gets the cartridges that go into these modules loaded up, the total runtime is about 45 minutes. So from run-in to getting an answer, you can see it's pretty rapid, less than an hour. We are currently validating the BioFire after the Cepheid, which I'll talk about next. Tentatively, the COVID panel from BioFire is not quite available, and they're expected mid-May at this point. And then again, when that comes out, it also still needs to be validated, whether it's here at RUHS or at another facility, just from a quality control standpoint. As you can see on the bottom, there's some other panels that we talked about, the respiratory panel, the pneumonia panel, blood culture ID, gastrointestinal panel, the meningitis encephalitis panel. So there's a lot of other uses. We're not expecting the BioFire to be running COVID 24/7. It's actually going to be used for a lot of other different modalities as well. So I'm very, very excited about this because a lot of these tests ends up getting sent out and you don't get results back for usually a week at least. And I know with Dr. Versio on the pediatric side, there's a lot of advantages for the respiratory panel that they're really looking forward to. The Cepheid, again, as we had talked about in the video, it has a lot of modalities, Group B strep, that can do TB testing for DNA analysis. There's a lot of other stuff. This one can be expanded up to 16 modules. That was the gray machine that you saw in the video. But each one of those little kind of boxes is a tested module. It has the similar runtime, 45 minutes. So once you get everything loaded up, it takes 45 minutes and you'll get a result. This is currently being validated right now in the RUHS system. The conservative expectations for validation, we're going to say around 2 to 3 weeks. Well, this was at the end of last week, so hopefully within the next 2 weeks. And then, of course, with any of these tests, the testing cartridges are really the rate-limited step along with the swabs. And again, you can see some of the testing things you can run here at the bottom right there. But again, this one potentially would be the main workhorse because if you just need a COVID test, you could run it on this machine, and it has 16 modules that you can run on. The Abbott ID Now, I'm sure a lot of people have heard about this on the news. This is also a PCR-based test. It uses only one particular, we could say, segment of DNA, so that's one of the contributions on why this is a little bit less sensitive and can create false positives, false negatives. There are different modalities. It's one little machine, as you saw, is kind of like that tan beige machine. So only one test can be run at it on a time. And then keeping in mind the laboratory worker has to be there to do this. If you have a positive result, that can come back again in about 5 minutes. A negative result usually comes back in about 13 to 15 minutes. We're hoping to get this formally validated by the end of the week at RUHS to get this up and running. When it first came out, it was reporting pretty low sensitivities, maybe around 85, 80%, and then a higher rate of false negatives. There have been some recent studies. A big one came out of, I believe it was Case Western last week, showing that with different preparations, you could potentially push the sensitivity up into the low to mid-90s, which was not quite as good as the other PCR testing, but much better than in the low to mid-80s at this point. The one caveat I would also really point out to other facilities, including ours, and really relying on the Abbott testing is the test kits are being, distributed by FEMA because they're so limited. So keep in mind, some facilities who have the Abbott have already run out of it and they have no idea when they're going to get it. Sorry, I think there's an echo going on here. So that's one thing to keep in mind with the Abbott. The reverse transcription PCR, or what I'd like to call the real-time PCR, RT-PCR, this was approved by our administration to obtain last week. This is, as many of you may have seen going through college and schooling, it's essentially a PCR machine, and it runs these plates. So the one we're looking at, and we have a new PhD here at RUHS who's helping to integrate this into the testing system. It's got 96 wells. 2 of those wells are going to be used for controls. So essentially you can batch 47 tests at a time. And what we're hoping to do is use this for planned procedures. So for example, anybody coming into the outpatient surgical clinics or outpatient procedure clinics, say for a GI procedure or something like that, what they can do during the clinics is do the test there so you can get tested prior to the procedure so that the patients, families, medical staff can know your status, the patient's status, if they're positive or negative. And these can be batched since there's no urgency to get this done immediately, and you'll have the results within maybe the end of the day. The testing time takes probably about 4 to 5 hours just because of it's a bit more labor intensive with the lab. But again, you're able to run a lot of samples at once, and this would greatly increase the volume of elective testing, along with potentially even spreading this into the clinic testing as well. And then by getting an answer faster for our patients and our employees, you know, this can help provide information for if people are going home, needing to stay or get off of home isolation and contact and stuff like that. So I think there's a lot of promise with this. This test, obviously, this machine actually can be used for a lot of other stuff, including research, so it's not restricted to PCR for COVID. It limits really up to the, you could say, the clinician and the scientist running the machine at this point. And then serology is, I think, the other big elephant in the room. So, you know, these are popping up all over the place. Most of these are not what we call EUA or emergency use authorized through the FDA. So most places need internal validation. You may have read in the news, such as places like Stanford, they've created their own serologies and then self-validated it internally in these big university settings. And they're high-functioning labs, so they can do this. And the tests end up being reliable a lot of the times once they're validated and if they're performed appropriately. I think the biggest question right now is how to utilize the serology test. And the Infectious Disease Society of America had put out a primer last week on potentially some ways you could use this. And these were kind of the 4 main issues that they had brought up. One was, you know, if somebody's PCR negative and maybe they're in a zone where you're not going to have a high detection rate with the PCR, you could do a serology primer to see if they have acute antibodies, or what we call IgM antibodies. Also looking at people who have been exposed and mainly don't have any antibodies for an acute infection, they could potentially be targeted as convalescent plasma donors to help severely ill COVID patients in the hospital. Obviously, epidemiologic studies to see how this has spread, potentially how many people have already been exposed. And interestingly, you know, we've probably seen that as different communities have run serologies, they've reported anywhere from, I think, you know, New York, they were saying at least 10% higher than what's been reported. And up in the Stanford group, they tested Santa Clara County, and I don't remember the number, but I think they were saying potentially there was 40 times as many people that were exposed as realized, which in many ways may be good at saying that even though there's a lot more exposures, most people didn't get ill enough to need to go in the hospital. But again, I think this will help in regards to the studying the disease progression. And then we talk about the vaccine. You know, if there is one that ends up being developed, serology could be used potentially to try to gauge if somebody's developed protective antibodies as well. And then that leaves a big caveat in the room about if antibodies really do protect you or not, and that still needs to be determined at this time. So and then again, these are kind of the main sendouts we already reviewed at the beginning here. So Public Health, LabCorp, and Quest at this point. So that's the end of the brief PowerPoint. I was wondering if anybody had any quick questions or dying questions they wanted to ask. I'm very, very excited to get these machines up and running, not just because for COVID testing, but where was that previously? We had all of these, and going from a facility that had these at the touch of a fingertip to not having them at all for the last 2 years, it's almost like, well, maybe not this extreme, but it's almost like, suddenly running out of water in a desert and just being thirsty all the time and not being able to do everything you can for your patients. So
yes. So if you have questions, go ahead and share them in the chat, and then I can raise those questions with Dr. Wang. I did want to, ask some of your thoughts on why we've chosen to pursue multiple modalities. And obviously, as you mentioned, some of this was already preceding COVID. So we had been, we'd purchased the Cepheid machine. It actually came shortly before this situation arose, and we purchased it for rapid GBS testing. One of the issues that we have here is that we have patients that either have not had their GBS done because they didn't have, close prenatal care, or it's done outside and we can't get, results over the weekend, et cetera. And so this, we are more cautious with the newborns for those patients because we don't know if they were exposed to GBS or not, and then have a higher risk of developing early onset sepsis. And so that was one of the reasons we pursued that, testing modality. And then obviously they came out with a COVID, testing after that. And then we'd also been working on BioFire as well. One of the things we have in pediatrics is a high number of patients that get admitted for respiratory issues to the PICU or our ward. And the only rapid testing we had at that time prior to this was flu and RSV. And so, it's always a question, do they have pneumonia or do they have a virus? Most pneumonias, or even in those under 1, are viral anyways. And so this gives us further capacity to kind of determine that question of whether it's viral or bacterial. And so this is something we pursued beforehand. But having said all that, having all of these different testing modalities is quite helpful. So, one of the things that different organizations are thinking about is the algorithms for use of different tests. What do you, we don't have to get deep into the algorithms, but what do you think about having so many different formats of testing available for us?
Yeah, that's a really great question. Everybody likes to have more toys, so to speak, or testing. And before I even go forward, I would extend a huge, there's been a ton of people involved in trying to get these testing system. I would definitely recognize, Greg Prouty. He's been one of our biggest advocates. Nikita Patel, who's one of our head ID infectious disease pharmacists, has also extended a lab sign. She's done a huge, and a lot of other people, but I just wanted to recognize those two people. But in regards to the testing modalities and how you pick what you do, surprisingly, I was actually going to be presenting that to our RUHS COVID committee this morning, but I think we'll kind of bump it a little later. So what we're looking at really is the urgency of the test and the need for finding an answer right away. And obviously, everybody wants to find an answer immediately if they can. The general overall thought is if you're coming into the hospital, it's better to know and get an answer quicker rather than later, because what this is going to help to determine is where you put the patients, what kind of what we call PPE or personal protective equipment you have. And as we've all seen in the news, there's a significant lack of that. This can also prevent delay in care for other maybe non-urgent procedures if, say, they need to go to surgery or get a colonoscopy or something like that as well. And, I think there's always, whether it's with all the employees, there's always a little bit of a fear involved. As much as we'd like to say we're as objective as possible, we're still human. So there's that factor. And even though you're donating all this personal protective equipment, at least not to say you're going to become more lax, but knowing somebody's doing everything to get tested and knowing that maybe they have a negative result might provide some reassurance. So saying that, in the hospital, in general, what we're advocating for is if you're coming into the hospital from the ED or direct admission, we're suggesting to use the rapid PCRs, which would be the Cepheid or the BioFire in those settings. And then in the clinic settings where you're planning for a procedure like an elective surgery, say a knee replacement, or you need a colonoscopy or whatever the case may be, and that's going to be planned, a few days out, or there's no urgency, then that would be actually directed toward what we call the RT-PCRs, which will still come back within a few hours, so you're not waiting for days and days. But again, this will still allow people to potentially get tested and go home as well. The serology, we're still trying to figure out how that's going to fit all into this. And then again, the Abbott ID Now, I think what's going to happen with that is that really would be like a last resort device if you don't have any other options. And my thought is probably with that, because the testing kits are so limited and FEMA is really controlling the distribution of that probably is going to end up falling by the wayside, because as soon as you run through your limited supplies of tests for that, you're not going to be able to run anymore. It's not something you can create in-house. So really for really acute testing, Cepheid and BioFire, and then for non-acute or non-urgent, where you have time to plan, the RT-PCR would be the preferred choice of testing there.
Yeah. Thank you for sharing that with us. What, knowing that some of these different machines are kind of in high demand, do you have any thoughts for our community partners that may not have, already purchased some of these different modalities for testing?
Yeah, so if I would say if you need to focus on one or the other, go with the Cepheid or the BioFire. Obviously, per test, the Cepheid is going to be cheaper because you're just running a COVID test, whereas with the BioFire, the COVID test is eventually going to be on what we call the respiratory panel. So you're not just running COVID, you're running a whole bunch of other viral testing, bacterial testing as well. So that test is going to be a little bit more expensive. Keep in mind, though, as the fall and winter season comes in, and then the 6 months after that, you're probably going to be wanting to test for that anyway. If an issue, and you had to only pick one, I think my choice probably would be and they both do different things, but the BioFire might help more in the hospital because of all the other panels you can potentially run on hospitalized patients. The Cepheid, of course, has a lot of other stuff, but I think there's a little bit more flexibility with the BioFire, but it is a little bit more expensive of a test. I think if your resources are just so limited and you want to increase the capacity of just being able to do rapid turnaround testing for COVID specifically, the Cepheid would still be a great option. When facilities purchase the Cepheid, you don't have to purchase all 16 modules. You could potentially just purchase 4 modules, and then you could gradually increase the modules for more testing if needed too as well. So maybe for just COVID-specific testing, the Cepheid might be what to focus on. And just talking to other ID docs in the Inland Empire, who are at facilities are very limited resources. That's what they've done, is looked at the Cepheid first, and then if they're able to, look at the BioFire, unless there's been internal demand for other testing.
Okay. Well, thank you so much for sharing your time with us this morning. Hopefully this has been helpful for both our employees here at RUHS to understand what we've very, I think, quickly acquired, thanks, like you said, in large part to Greg Prouty and Nikita Patel. And then also hopefully this will be very helpful to our community partners as they're kind of looking to expand their testing capacity for this. Likely this is going to be an issue in the fall, as you mentioned, with when flu season starts and RSV season starts for us in pediatrics, determining whether they have COVID-19 or something else is going to be, really, really important. So, all right, that will wrap up our webinar this morning. Thank you so much for joining us.
Thank you.